عليه وصحبه. Good evening, everyone. This is Dr. Umbarak al-Mansour, medical oncologist, Princess Noor Oncology Center in Jeddah. I would like to thank the President and the Vice President, Dr. Faras al-Freih and Dr. Amal al-Bihani, for taking the lead for the continuous education during the COVID era, and also the great participation from all of our audiences. And also would like to thank the Saudi Society for the Blood Disorders for this organizing this event. Tonight we have a session 2 of the update from the 2021 ASCO and EHA webinar series with the lymphoma and CLL. We have very distinguished speakers tonight. We'll go through the Hodgkin, non-Hodgkin, and a CLL. And we have a very motivated and interesting program. We'll start with the first part with the Hodgkin and non-Hodgkin lymphomas. That will be followed by a discussion session with my friend Dr. Musab Dammaj. And then we will and then we will proceed to the session number 2 with the CLL, and that also 2 lectures will followed also by a discussion from all the speakers and as well as from all the audiences. Mashallah, I've seen the number reaching now up to close to 600. So expecting a very interactive discussion, and we'll do our best to finish all the part on the allocated time. So we have 2 hours for the whole program. Without any further ado, I would like to welcome the first speaker, Dr. Riad Al-Faqih, a senior hematologist and BMT transplant at King Faisal Specialist Hospital in Riyadh, and his part in Hodgkin lymphoma update from ASCO and EHA. Dr. Riad, welcome, and the mic is yours.
Thank you much, Dr. Mubarak, and for SSPD for organizing this event. I hope you can see my slides clearly. So I was asked to present the ASCO and EHA updates regarding Hodgkin lymphoma. And I chose 6 abstracts that I think they may have impact on our clinical practice and have, in the future may lead to change in the practice a little bit. So we can start with the first abstract. It's the abstract 205, and this is the 5 years update of the Echelon-1 trial. We're all familiar with the Echelon-1, and as you know, this is a study, phase 3, comparing advanced Hodgkin lymphoma cases, stage 3 and stage 4, between 2 groups. One is treated with Brentuxi AVD, and the other is treated with the standard ABVD. So, and as you know, the majority of relapses in classic Hodgkin lymphoma, around 97%, of the relapses would happen within the first 5 years after finishing therapy. So the primary endpoint of that trial was progression-free survival. And this is the 5 years update. So probably the gain, we're talking about it now at 5 years, and the progression-free will be reflected as an overall survival benefit. So again, the majority of relapses in Hodgkin lymphoma happen within 5 years. And this study, the Echelon-1, is AAVD versus ABVD for advanced Hodgkin lymphoma. So the population was sizable, 1,334 patients, and it was an open-label, multi-center randomized trial, and the maximum number of cycles allowed was 6 cycles. We know from the previous reports about the 3 and 4 years progression-free survival benefits for the Brentuxi AVD arm as compared to the ABVD. Both these reports were published already, and we know that the improvements in and the PFS was irrespective of the interim PET scan results, the disease stage, and baseline disease risk factors. So this is, again, the 5 years follow-up. And as you see here, the median follow-up is around 61 months. And the 5-year PFS was 82.2% for the Brentuxi AVD versus 75% for the ABVD. And that was statistically significant with a p-value of 0.002. If you see here, per intention to treat population, also the PFS was in favor of AAVD as compared to ABVD, with 85% versus 79%. So around 6 to 7% point benefit in progression-free survival at 5 years. And probably this will be equivalent to an overall survival benefit. As we said on the first slide, most of the relapses would have happened by 5 years. Now, this comes to a price, with a price. We all know that AAVD has more neuropathy than ABVD. The good news, the majority of these neuropathy resolved in these patients, 85% in the AAVD versus 86% in the ABVD, resolution of the peripheral neuropathy. However, the median time to resolution was higher in the AAVD. So it was 34 weeks in the AAVD versus 16 weeks in the ABVD. So almost double the time for resolution. As far as the grading of the residual neuropathy, most of the cases were grade 1 in both arms, with 17% in the AAVD versus 14% in the ABVD. Secondary malignancies happened in 19 patients in the AAVD versus 29 patients in the ABVD. This was not statistically significant. And regarding infertility, which is a very important issue for this young population, 131 pregnancies happened in both arms, and there was no reports of stillbirth. So 87% in the AAVD pregnancies happened in the AAVD and 75% in the ABVD. And in this table, it's a summary about the progression-free survival in between both groups in terms of the baseline risk factors and the PET2 status. And as you see, the PFS was preserved in almost all subgroups, except in a PET2 positive group in patients less than 60. It was not maintained. So we move to the second abstract. The second abstract is also related to the Echelon-1 trial. This is a subgroup analysis of the Echelon-1 trial, looking into the outcome and the side effects of the AYA population on that trial. As we spoke on in the previous slide, this treatment can lead to peripheral neuropathy, fertility issues, and second malignancies. And these side effects probably are more important for an AYA population, which is a young population. So the investigators on this abstract used the NCI AYA definition, which is age 15 to 39, and they looked into that population that was recruited on Echelon-1. So out of the 1334 patients, 771 were AYA, so aged between 15 and 39. So this is around 58% of the total population. And almost half were treated with AAVD versus ABVD. And the median follow-up was similar to the Echelon, 5 years. The 5 years PFS was 86% for the AAVD versus 79% for the ABVD. So it's almost the same amount of benefit described in the Echelon-1. PET2 positivity in this population, defined as doable 4 to 5, was 6 and 8%. And the PFS benefit was independent of the PET2 status. So all in all, the reduction in the risk of progression in the AYA population, progression or death, was 36% in the AAVD versus ABVD, and that was statistically significant. So if we look into the details, we see that around 20% of the AAVD people needed salvage versus 26% on the ABVD, and around 7% of the AAVD underwent O2 versus 9% on the ABVD. In terms of peripheral neuropathy, the resolution was similar in both arms with 88% and 89%. And the ongoing peripheral neuropathy was predominantly grade 1, as you see here. However, if you look into the ongoing grade 3, it was, so 13% of these were on the AAVD arm versus 5% on the AAVD. And this is grade 3 neuropathy, which is pretty significant and can be irreversible. Secondary malignancies, as previously reported, around 2% in the AAVD and 1.4% in the ABVD. Subsequent pregnancies were reported in females and males, partners of males on that study. And there was no difference in between the two arms. All these pregnancies happened in patients less than 40, except one of them, and no stillbirths were reported. So all in all, the results in the AYA population were consistent with the echelon total population results, and maybe numerically, if you look into the details, a little bit better outcome in the AYA population. We move to the third abstract. This is the CALGB 50801 study. And this study looked into a PET-adapted approach to avoid radiation in early stage bulky Hodgkin lymphoma. So it's only early stage, stage 1 and 2 bulky Hodgkin lymphoma, and PET-adapted to avoid radiation. Okay, as you all know, bulky disease has inferior outcomes in Hodgkin. And historically, we treated these patients with a short course of ABVD plus radiation therapy. So this trial tested a PET-adapted approach where they did a PET after 2 cycles. And for PET-negative people, they continued on ABVD for 6 cycles. For PET-positive, the treatment was escalated to BIACAP plus radiation. So eligible patients were up to the age of 60. And again, early stage bulky disease defined as more than 10 centimeter or 33% of the chest diameter by chest X-ray. Patients were treated with 2 ABVD, and PET negativity was defined as duofil 1 to 3. Patients who were PET negative received 4 additional ABVD without de-escalation, and PET2 positive patients received 4 cycles of BIACAP plus 30 gray of involved side radiation therapy. Primary endpoint was PFS from PET2. And this abstract summarizes the results 3 years after the last patient was enrolled on that trial. So 101 patients were enrolled, but only 94 were evaluable. Median age 30, 53% females. And here you see the split of the grouping. The majority were 2B. After starting therapy, around 80% of the patient achieved PET2 negativity. The majority of the patients who were PET2 positive had stage 2B disease. The 3 years PFS, so that's the primary endpoint, was 93% for PET2 negative versus 89.7, so almost 90% for the PET2 positive. And this is a surprising results, actually, because the PET2 positive patients usually have bad outcomes. So here we see with the escalation to BIACAP plus radiation, they did as good as the PET negative. All in all, if you do the total population, the PFS at 3 years was 92.3%. 3 years overall survival, 98% for PET negative, 94% for PET positive, and 97.7% for the whole population. So excellent PFS was observed. And radiation therapy was omitted in 78% of the patients by adapting this approach. And here we can say that PET2 positive treated with escalation had as good outcomes as the ones treated who got PET2 negative. We move into the fourth abstract. This is an abstract evaluating a new antibody, anti-PD-L1 checkpoint inhibitor. It's called pembrolizumab. And this antibody is a humanized immunoglobulin 1 antibody that blocks PD-1 binding to PD-L1. So the difference between the regular checkpoint inhibitors is the way this a new antibody binds its epitope. And this antibody was engineered in a way to decrease the elimination of this antibody and thus increase the binding to the target and increase the efficacy. At the same time, it was engineered to eliminate the FC-mediated effector function that can affect the safety of these checkpoint inhibitors. As you see here in the phase 1 trial, this antibody demonstrated slower PD-1 antigen binding off rate than all the marketed anti-PD-1 antibodies. And as such, it results in better cellular activity and higher receptor occupancy. So with these structural differentiations, this antibody may have an enhanced anti-tumor activity and superior safety profile. So this study was a multi-center study, single-arm open label, in patients with relapsed refractory classic Hodgkin lymphoma. The treatment was 200 milligrams every 2 weeks until progression or unacceptable toxicity. Eligible patients must have had a prior auto transplant and failed after that, or at least received 2 lines of prior chemotherapy. The primary endpoint was overall response rate per Lugano 2014 criteria. Secondary endpoints were CR, PFS, duration of response, safety, and tolerability. And as you see here, 94 patients were treated, around 60% males, median age 32, and most of them were ECOG 0. A quarter were ECOG 1. So of these 94, 56 remained on treatment by the time of this abstract presentation. 4 of these 94 patients completed the 24-month treatment and stopped therapy because that was the allocated treatment period. 25 discontinued the drug, 17 due to disease progression, 3 to side effects, and the others unknown reason or variable reasons. So after a median follow-up of 16 months, 15.8, 85 evaluable patient, and the overall response rate was around 90%. And around 47% were CRs. So around half CRs and around 90% response rate. Median duration of response was not reached, and it ranged from 1.7 up to 24.5 months. At 12 months, the PFS was 72.1%. Adverse events were seen in almost all the patients, but the grade 3 were 26%, and the treatment discontinuation due to side effects was 5.3%. And as you see, the side effect profile is comparable to the other PDL inhibitor. So they were hypothyroidism, URIs, fever, ALT, AST elevation, and so on. So again, this drug has shown good efficacy with a CR rate of 47.1%. And the safety profile was consistent with the available drugs of the same class. This is another monoclonal antibody called tislelizumab, and also it's an anti-PD-1. Again, it was engineered to minimize, the Fc gamma receptor binding on macrophage, and as such, decreasing the antibody-dependent phagocytosis, which is a mechanism whereby the T cells clear these anti-PD-1 therapy, and this is how these patients develop resistance. So basically, it's pretty much similar engineering to the previous antibody. The idea is to increase efficacy and decrease the side effect. This drug was studied in a phase 1 trial, which is already published in leukemia. And this is the 3 years follow-up study of that same population, plus the additional patients enrolled on this protocol. So single-arm, multi-center phase 2 study. This drug was given every 3 weeks until progressive disease or unacceptable toxicities. Patients' inclusion were failure to achieve response or progression after autologous transplant, patients who received 2 lines of prior therapy or were ineligible for autologous transplant. Primary endpoint was overall response, pretty much the previous endpoint, and the secondary endpoints were PFS, duration of response, CR rates, time to response, safety, and tolerability. So as you see here, 70 patients were treated, and median follow-up was 33 months. Around half of patients still on therapy. 13 of these patients had prior auto, and impressively, 11 of these 13 achieved CR with this drug. The adverse events were pyrexia, URI, hypothyroidism, and weight gain. Grade more than 3 adverse events were pneumonitis, hypertension, neutropenia, chemical pancreatitis, weight increase, and myositis. So again, the side effects were mainly autoimmune, and they were reported in 32 patients. And 8 patients had more than a grade 3 immune toxicities in terms of pneumonitis, skin reactions, and nephritis. These adverse events led to treatment discontinuation in 6 patients, which is 8.6%. So on this table is a summary of the overall response rate, 87%, CR 47%, median duration of response 31 months, median PFS 31 months, OS not reached, and a 24-month event-free rate was around 94%. Last abstract is salvage options in Hodgkin lymphoma. As you know, many salvage regimen are used, and each institution is used to one of these salvage. So this study was a retrospective collection of patients who received salvage in 3 Mayo Clinic sites, and these patients were collected from the database, and their medical record were reviewed retrospectively. And they did study some association with the outcomes like age, sex, B symptoms, stage, bulkiness of disease as defined by more than 6 centimeter, extranodal involvement, primary refractory, and early relapse after frontline therapy. So 207 eligible patients were included. The median age of these patients was 33, 53% were males, and 52% were advanced in stage, and a quarter had bulky disease, 36% had B symptoms, 31% extranodal, and so on. So pretty much a representative population of what we see when we have relapsed refractory Hodgkin going into salvage. So all these patients received salvage and underwent autologous transplant. Some patients, around 21%, had to receive 2 salvage to achieve good remission, and a minority received 3 and 4 salvage. 6 groups of salvage therapy were identified, and these are some of the most commonly used salvage, like ICE, which is the most commonly used worldwide, and then bendamustine brentuximab, and these two were the majority of the salvages. BV alone, gemcitabine based therapy, checkpoint inhibitor, and others. So in this study, they found out that brentuxi, bendamustine had significantly much better overall response rate and CR rate when used in the first salvage setting. So as you see here, 114 of these 207 received ICE, and 79% of them, of these 114, responded, while after BBV, 97% responded. So almost all of them responded to BBV, and 56% BV alone, the response, 76% to gem-based protocols, 73% to checkpoint inhibitors, and 79% to the other. As such, a higher number of patients were bridged by use the BBV as compared to ICE, and that was statistically significant. And as you see here, 53% of the patient went to autologous transplant in CR, 36% in PR, 11% with progressive disease. 43 patients received BV maintenance, and they showed that patient going into transplant with PR or progressive disease had worst PFS as compared to patient in CR, and this is what we always see, and this was statistically significant. No difference in PFS and OS per salvage, and by using BV, PFS was prolonged as compared to the patient who did not receive BV in maintenance. Patients who were transplanted in CR, so they compared their salvage regimen, and they did not find any difference in PFS and OS. So if you achieve CR, it doesn't matter what you received, okay? PFS and OS were the same. So in conclusion, the type of salvage did not affect survival and response. Response and number of salvage did affect survival, but not the type. For patients in CR, the number of salvage, not the type of salvage, predicted survival. So if you're in CR, it doesn't matter what you received. What it matters is how many salvage you received. And brentuxi BV had the highest response rate and rates to bridge to autologous transplant. And here you see a tabular view of these results. And again, as you see, the BBV resulted in an overall response rate of almost 100%. It's 97% as compared to the others. With that, I will finish, and thank you all for your attention.
Thank you so much, Dr. Riad. Very comprehensive. To all the abstracts might also be potentially changing the practice. We'll leave the discussion also after the second part. I would like to welcome the second speaker, Dr. Riad Dada, consultant of medical oncology, section head of medical oncology at King Faisal Specialist Hospital in Jeddah. Dr. Riad will be talking on the non-Hodgkin lymphomas update from the ASCO and EHA 2021. Dr. Riad, mic is yours.
Assalamu alaikum wa rahmatullahi wa barakatuh. Thank you, Dr. Umbarak, and thank you, Dr. Amal, and the Saudi Society for Blood Disorders for the invitations. He was requested to speak about the non-Hodgkin lymphoma part. And the slides, what we will see are about abstracts demonstrated in the ASCO, and many of them, they were again presented on the EHA. So you will see shared slides. So I will start with the indolent lymphoma part. And the first trial is from France, is dealing with the outcome. It's a retrospective trial dealing with the outcome of patients who were diagnosed with COVID-19 and hospitalized in the hospitals. This is from 16 French hospitals. Patients diagnosed with COVID-19 during the pandemic, as with the initial phase of the pandemic, which is in March to April 2020. The patient, they had a lymphoma, whether active treatment or on maintenance or whatever. The patient's prolonged length of stay was defined as more than 30 days in the hospitals. And these are the patient characteristics. More than half of the patients, they received anti-CD20 directed therapy. Majority received chemotherapy. Some of the patients, they were post-allogenic stem cell transplantation, and many of the patients, they were in complete remission. If you look to the patient's age, 70 and more, when we looked at the entire population, the included patient 111, out of them, around 40% of the patient, they were 70 and more. Out of the patients who died, as 24 patients passed away, 71% of the patient, they were aged 70 and more. And patients who had comorbidities, multiple comorbidities, they were at risk of death more than others, even if they have, according to the subtype of the lymphoma, diffuse large B-cell lymphoma, 63% out of the 24 patients who passed away. The conclusion of the authors is that patients with B-cell lymphoma with COVID-19 have a high incidence of prolonged stay. It was reflected in the length of stay, more than 30 days. The administration of anti-CD20 therapy within the last 12 months is one of the main risk factors for a longer length of stay. And the risk of prolonged COVID-19 was also higher in patients with a higher age, 70 or more, and have multiple comorbidities. So the next study in indolent lymphoma is the Kronos-3 randomized phase 3 study with the PI3 kinase inhibitor copanlisib. It is being combined in this trial, in this phase 3 trial, with rituximab in patients who are CD20 positive and have indolent lymphoma, follicular lymphoma, marginal zone lymphoma, etc. The patients, they relapse following a regimen containing rituximab as anti-CD20 directed therapy, whether rituximab or other new agent like obinutuzumab. The patient must have a progression free treatment interval of 12 months and more. The patient were randomized to copanlisib plus rituximab versus placebo and rituximab. The primary endpoint was progression-free survival. These are the patient characteristics. If we look to the distribution, you can't believe me that the 307 patients on the left side as 1 to 2 randomization and 151 on the right side, they were equally distributed with the exception of median time since diagnosis in months. It was 62 in copanlisib arm versus 72 on a placebo arm. These are the objective response rate, which is the secondary and not the primary endpoint. You can see here that there is a major difference, a significant difference, as you can see here above the diagrams in the p-value. The copanlisib arm, the patients, they had 81% overall response rate in comparison with 48% overall response rate in the placebo arm. This is reflected also in the other subtypes as a follicular lymphoma, patients, which is the majority of the patients, and marginal zone lymphoma. The complete remission rate is very interesting in the overall population, 34% in the follicular lymphoma subtype, 37% in the marginal zone lymphoma subtype. Just to mention examples, was 39% of the patient who reached complete remission. This is the primary endpoint curve. You can see a beautiful curve here after median follow-up of 19 months. The median progression-free survival for copanlisib arm, it was around 22 months versus 13.8 months, which is statistically significant with a hazard ratio, very interesting, 0.52, favoring, as you could see, copanlisib. This is the benefit of progression-free survival benefit was seen across all subtypes: follicular lymphoma, marginal zone lymphoma, SLL, and so on. The conclusion of the authors: overall, copanlisib plus rituximab presents a potential new treatment options for patients with relapse disease across all subtypes of indolent non-Hodgkin lymphoma. The next trial, what I want to share with you, is a phase 2 trial with a new BTK inhibitor as proton kinase inhibitor about zanubrutinib in patient with relapse and refractory marginal zone lymphoma. 68 patients were included and treated with the oral treatment, zanubrutinib. Primary endpoint is overall response by independent review committee, which can be seen here on the left side of the diagram. The overall response rate in these refractory or relapse patient was around 70%, with here an interesting complete remission rate of 26%. This is the progression-free survival duration. As you can see, if we take the cutoff 12 months, you can see here that of those who were responding, more than 80% of the patients, they maintained their response after 1 year. This is the safety profile. The yellow color in this swimmer plot is reflecting the grade 3 and more AEs. You can see here it's manageable, no major percentage except neutropenia grade 3 and 4. It was seen in about 10% of the treated patients. The summary of the trial is that zanubrutinib has a high activity with a favorable safety profile in patients with relapse and refractory marginal zone lymphoma. So no abstracts, no conferences, new days without mentioning something about the CART. This time is it the ZUMA-5 with axi-cell in relapse and refractory indolent lymphoma, who had at initial diagnosis the high risk feature of progression within 24 months, as of POD24, as of initial when the patient diagnosed with a high LDH, high FLIBI score, etc. The patients were treated with a normal chemotherapy, and they were allowed to be treated with axi-cell if they failed 2 lines and more. This is the flow of the axi-cell study. These are the patient's characteristics. So if we look to the median number of previous therapy, 3 and more, it was in 60% of the patients. So a quite not easy to treat population of patients. Some of the patients, 20%, they failed autologous stem cell transplantation. And most of the patients, they had advanced diseases. 83% had stage 3 and 4. This is a beautiful overall response rate, whether the patient relapsed within 24 months or after 24 months. The overall response rate was amazing, 92% in both groups within 24, or after 20 months relapse. Out of these patients who were included in the study, it's worth to mention that 63% of the patient, they relapse within 24 months, and just 37% of the patient did not, as they relapse after 24 months of initial treatment. The duration of response, it was not reached in both diagrams as duration of response and progression-free survival. But if you look here as example, let us take after 2 years out of the patient who responded, 60% they maintained their response. Similar figure as around 60 or 55% of the patient, they were progression-free after 24 months. The overall response rate hasn't been reached, but again, here it will do the same exercise, maybe this time with after 3 years. You can see here that after 3 years, around 60 to 80% in the other groups were still alive as after 3 years. The conclusion of the authors, Axis-Hill demonstrated a high rate of durable response in patients with POD24 indolent non-Hodgkin lymphoma. Because of the time, I did not speak a lot about the safety profile. It was manageable, similar to other group of patients. Then another new combinations, the combination of venetoclax, Revlimid, and Rituximab in patients with newly diagnosed mantle cell lymphoma. This is a phase 1 trial, but quite interesting. Untreated mantle cell lymphoma who required treatment. We know that not all newly diagnosed mantle cell lymphoma, like follicular lymphoma and other indolent lymphomas, they are requiring treatment. The patient, they were treated for 12 cycles, as of 1 year, 28 days cycles, Revlimid 20 milligram, day 1 to 21, venetoclax for 100 milligram oral daily, and Rituximab, so the intensive dose of Rituximab was given in the first cycle, day 1, day 8, day 15, and day 22. Then the patients they continued their treatment for another 2 years with Revlimid and Rituximab, and another following 3rd year with Rituximab monotherapy. These are the patient characteristics. If you try to analyze that, you will find that these patients, they have quite high MIPI score, as a bad risk. Nearly all of them, they had intermediate and high risk, and the median age of the patient, it was 65%. Looking to the Ki-67, 30 and more, which known to be not very as an unfavorable prognosis. Out of 29 included patients, 19 had Ki-67 of 30% and more. These are the radiological responses. You can see that after 3 months out of 29 patients, all of them, they responded well to treatment. Here, the big chunk of the patient reach even a complete remission. Similar data after 12 months, with the exception that across the time, several patients, they were dropped off of the study. Then the minimal residual disease response, which is the primary endpoint for this trial, was seen after 3 months as a negative MRD was reached in 63% of the patients after 3 months. And so on, you can see here very beautiful orange filling of the diagrams here. This is reflecting the negative MRD in patients with this very bad to treat disease. What about the adverse events? 58% of the patients, they were suffering from neutropenia, grade 3 and more. As the hematological toxicity here is an issue, and there was 2 secondary cancers, adenocarcinoma and skin cancer. Maybe this is related to Revlimid. It has been reported in myeloma patients that patients who are receiving Revlimid beyond 2 years might be exposed to a higher risk of secondary malignancy. There were also 4 deaths on the study, 2 lymphoma patients, 2 due to the lymphoma, and 2 from other causes. Now we're coming to the aggressive lymphoma. First line treatment, I have only 1, I think, abstract in the first line, which is dealing with the intensification of R-CHOP versus R-EPOCH among patients with advanced stages with double hit or triple hit diffuse large B-cell lymphoma. Until now, we don't have any highly effective regimen in this bad prognosis patients. Different trials have been conducted in order to optimize the outcome for double hit and triple hit patients with diffuse large B-cell lymphoma, but unfortunately, until now, we don't have any study which is showing reliable results in terms of overall survival improvement. This study here is a retrospective trial. It was conducted over nearly 10 years, and patients were screened whether they have MYC rearrangement. If yes, then it was double hit or triple hit. By the end, they looked to MYC rearrangement patients only. They were 64 patients, and for double hit patient, 117, triple hit patients were 37 patients. The majority of the patients, I must say, they received R-EPOCH as a dose intensification, dose intense chemotherapy, and only 43 patients received R-CHOP. Here, I think the overall survival curves, they are on the left side. This is more interesting than the right side. The right side is just for MYC alone, and the left side is for double hit and triple hit patients. There is no significant difference in the overall survival. And this is the more important. I mean, we do have some data with R-EPOCH, with retrospective data and randomized trial which showing a benefit of superiority of R-EPOCH over R-CHOP, but in terms of progression-free survival and not overall survival. So relapse refractory diffuse large B-cell lymphoma, maybe here we can touch a little bit on a new agent, mosunetuzumab. It's a new agent which is a humanized IgG antibody, bispecific antibody, engaging the T-cell receptor with the CD33 and on the T cells and CD20 on the B cells. CD20 is on the non-Hodgkin lymphoma cells. The idea is to bring the T cell closer to the CD20 positive lymphoma cells in order to destroy it. And the patients were treated with this drug, as well the B-specific antibody, together with polatuzumab. There were different doses here which were tried with the new agent, and these are the patient characteristics. You can see nearly all patients, 82% of the patients, they had advanced stages. The median prior therapies received 3. Some of the patients, they failed even CAR-T therapy. These are the adverse events prior the response rates. There were a grade 1, just grade 1 cytokine releasing syndromes, grade 3 and more Neutropenia was seen in 41%, but despite this high number of high percentage of neutropenia, no febrile neutropenia was observed with these novel combinations. These are the data on the response rate. The best of response as an overall response rate was 68%. This is really relapsed and refractory patients, and some of them they failed CAR. This is really very interesting and motivating, and many of the patients reach even a complete remission. So patients who are responding, you can see here in this swimmer plot that their response, they maintain response over a long time. This is really quite interesting, and we are seeing this more frequent now with the monoclonal antibodies therapy, whether immunotherapy or base-specific antibodies. The last abstract what I want to share with you is the safety and efficacy of a new agent with the CD37 antibody, Naratuksimab. Naratuksimab is having the same M10 poison, which is in trastuzumab in breast cancer and TDM1. The patients were treated with Naratuksimab plus rituximab in diffuse large B-cell lymphoma and other refractory B-cell lymphoma. It was a phase 2 trials.
1 minute, Dr. Riad.
So I will be finished. That's the last abstract. So we'll focus here in the cohort 2. 33 patients were included. The drug was given here every 3 weeks, here weekly. This is the response rate. You can see here really very interesting response rate. The overall response rate was 50% in cohort A on the right side and cohort B on the left side. The duration of response, look here, after 2 years, around on more than 50%, they kept their response with this novel treatment. The safety profile, the most frequent observed grade 3 to 4 is were hematological nature. Of the 20 patients with grade 5 AEs, 2 were considered as relapse to treatment. Neutropenia here, around 50% of the patient, they had neutropenia, and discontinuation of the treatment, just 8%. Yeah, that's it. Thank you very much.
Okay, thank you so much, Dr. Riad. I would like to invite Dr. Musab Damlaj. He's consultant hematology and stem cell transplant at King Abdulaziz Medical City in Jeddah. And he will be also running the discussion for the first and second part. I'm giving him the time to manage because I think we have a total of 20 minutes discussion. So Dr. Musab, the mic is yours. And we might also, if we have no time in the first session, we can also ask the other questions with the CLL part. Thank you.
Absolutely. Thank you, Dr. Umbarak. We have a few minutes for discussion now, and then we'll also debrief again after Dr. Mansour's talk. The audience, you're welcome to type your own questions, the same for the panel. And while we're waiting for that, I can probably kick off some questions of my own. Dr. Riad had a lot of interesting abstracts. It's very difficult to keep up with everything. Just a couple of things. The first one, when we talk about copanelizumab, we're still trying to learn how to pronounce it properly. As a class, as a new class actually, or medication in indolent lymphoma, when idelalisib came up initially and it was approved, as you know, it didn't really pan out, not because of efficacy, but mainly because of toxicity. Are we seeing a similar side effect profile with this? Do we think it's going to be a class effect, or this new medication seems to be more safe and hopefully it's going to lead to using this class in indolent lymphomas?
This is an interesting question. I think the side effects are similar. The efficacy is more seen. This kind of trial is as a phase 1 trials to reach a phase 3 trial is really interesting. I must say, anecdote, so we were offered actually to participate in this trial, so 1.5 years back, but unfortunately we rejected because of it has to be given frequently for the patient, and you know our patient population, they are coming from far away, they have to come on day 1, day 8, and day 15, and we rejected to participate in this very interesting trial. Yeah, the side effect profile is quite similar.
I see. Okay. One more question about the ZUMA-5 trial. Responses are very impressive. Usually, as you know, in follicular lymphoma, when our patients fail bendamustine or fail the conventional treatment, really, and then they, especially if they're in the POD24 category, these patients really tend to not do very well. So when do you think is the right timing for CAR-T referral? Do we wait? So after we use second line, we proceed for CAR-T, or should we explore other treatment options?
This is the $1 million question. Nobody can answer this question, but I think I'm certain that the CAR-T, because we are seeing more and more data, and the data are maturing more and more. And we have seen in the last few conferences that many patients, they have a prolonged progression-free survival, which is really motivating all of us to incorporate such novel treatment in earlier lines of treatment. I am certain that it will come in the third line in difficult to treat disease, mantle cell lymphoma, maybe earlier lines, I think, in the near future.
It also costs $500,000. If it's,
Good.
I have one question from the audience. Please, can you give us some statistics on Hodgkin's lymphoma and non-Hodgkin's, either in King Faisal or another hospital? Maybe Dr. Riad Al-Faqih can answer this.
I don't have very accurate statistics, but I can say we get in Saudi Arabia around 300 to 400 new Hodgkin, maybe a little bit more in recent years. And a quarter of them are seen at King Faisal. Quarter, I would say 20%. So this is the average. Now it may be a little bit more in the recent years, I think so.
And we at National Guard in Riyadh, we probably see around somewhere, depending on the year, but somewhere between 30 to 40 new cases of Hodgkin per year, and maybe a similar number of every other lymphoma. And if we probably see around 60 to 70 patients total of lymphoma per year. But obviously, it's difficult to extrapolate on a country-wide based on 1 or 2 centers. Because many patients present to peripheral hospitals and they get treated with frontline treatment there. But based, I think, on the latest Saudi Cancer Registry report, if I recall correctly, it is something like this, maybe around 400 new cases of Hodgkin lymphoma per year. I don't remember, honestly, the non-Hodgkin numbers, but they are available.
Can I ask Dr. Riad Al-Faqih one question about the presentation? 1 minute maybe. Dr. Riad, about the bulky disease management, the abstract was presented by Lucas. 2 important messages. I mean, one of them is that the bulky disease, even if it's a stage 1, it should be treated as advanced stage with the 6 cycles, either with the escalated via COPE, which was into the escalated arm, or into the arm with the ABVD. And after 2 cycles with the ABVD, about 78 achieved a complete metabolic response on a PIT 2. I think what is the practice now, most of the people, they are using the ABVD for the bulky. I'm not talking about the advanced stage with the Naratuksimab AVD, but most of the bulky disease still using the ABVD, and the restaging is done after 4 cycles with the CT or PET, and still achieving a good response, even with the radiotherapy for those with the residual positive PET. So my question about the escalated BioCOP arm, because in that study, we don't have the ABVD 6 cycles plus involved field radiotherapy to see what is the differences between two. So is it a practice changing for you at this time for those patients achieved PET? PET still PET positive after 2 cycles. Would you escalate? Would you proceed with the ABVD and then go and see if that will be just maybe early, I would say.
It was, the study is around 100 patients.
Yeah.
And, in Hodgkin studies, we usually get a lot more before we change our practice. Now, BioCOP is not an easy regimen, and this population is young people. First of all, you have to have all the logistics to apply BioCOP. We don't use BioCOP, by the way. You have to accept a much higher rate of infertility and secondary cancers in these patients, and most of them are young. So this is what plays against BioCOP. Now, PET2 positive has been for a long time known to be a bad sign, and these patients would get around 30% PFS at 5 years in most of the studies. Now, this study is very impressive because up to around 90% PFS at 3 years with this escalation. I don't think we will change therapy, a practice, I would say. The other question is, what if you involve some of the new agent when you have PET2 positive, Naratuksimab AVD? You escalate to this type of therapy, which is not as intense as BioCOP. So these are all questions. In our practice, we did not actually. What we did decide to do is keep going to 4 cycles, re-image, PET positive, then go for auto transplant, PET negative, then give more chemotherapy. But we did not adopt BioCOP.
And so what they did 2 interventions in the PET positive group, which makes it difficult to interpret the exact magnitude of benefit in each one. If the radiation enough by itself, then usually in these limited stage disease, we give them the 6 cycles and then we irradiate. And then but nonetheless, I agree, the results were impressive, but I think it's difficult to know exact magnitude of each intervention.
So maybe allow me 1 sentence. In this regard, there are different approaches. The most common used approach in Europe and maybe US, not US, but in Europe, is to escalate to, as this study is doing, patients who are PET positive. After 2 cycles, they will go for escalation with BCOP followed by radiation. But there is another approach, which is patients who, and this is recommended, and I think you will see it in the NCCN guidelines if they haven't changed it. You will continue with EBVD despite having a PET positive disease, but the patient, they must respond to treatment. You can continue to 6 cycles, total of 6 cycles EBVD followed by radiation, regardless the results of the end of a treatment PET scan. This is one approach. And the other approach, which I less favorite, is to make the radiation depends on the final PET scan. As there are here, you can see here, there are different approaches how to tackle the patients.
Good. Okay, great. If you allow me, Dr. Musab, we have to proceed maybe to the second part. And then we will go back to, if we have more questions about the session, into the discussion part after the CLL. So we'll proceed to the session number 2 with 2 presentation on optimizing the management for the CLL and into also update on a CLL. We have the first speaker, Dr. Mansour Al-Faiz, consultant hematologist at King Fahd Medical City in Riyadh. He will present into the CLL optimization management. And then we'll go directly to the second talk by Dr. Salim. Dahda is also a consultant hematologist and also stem cell transplant at Princess Noor Oncology Center. So just saving a time, we'll proceed with Dr. Mansour, and then Dr. Salim directly will proceed with his second talk. So Dr. Mansour Al-Faiz is the first.
Okay, let me share my slides. Slides being shared.
Hi.
Yes. Go ahead.
Hi everyone. I'd like to thank the sponsoring agency and the organizing committee for this meeting. In today's talk, I will be discussing my approach to CLL. So we'll be trying to talk about optimizing the management of CLL with advances in the northern regions. This talk is sponsored by the SSPD and the Johnson. However, the slides are mine. The presentation reflects my opinion. We'll try to cover 3 objectives in this meeting, or this short presentation. Frontline management with a focus on high risk, that is 17p and TP53, and the unmutated IGBH. We'll address some of the side effects, particularly in continuous treatment, where there is more challenging where it's more challenging compared to treatment. And last, we'll be discussing what I think the future might hold in the treatment of CLL. My colleague Salim will be presenting, Dr. Salim will be presenting the highlights of the Riad. There is a few abstract I highlighted here. I will not be going through them. Dr. Salim will be, but the CLL14 update, the Captivate, the Hoven, Glow, Plane, and Elevator R. There was also the Elevate 4 years update and Resonate 7 years update. And there was an abstract about treatment in Moran. So I'll start with the first question, which is frontline treatment. Which screen I'm sharing my screen, or I just want to confirm.
Yeah, you are sharing your screen, but can you click to proceed because it's
stick.
Yes.
Sure.
Yes, it's going now. Okay.
How about now?
Yes, go ahead.
All right. So this is what I was talking about on the abstract. So we'll start with the frontline treatment of 17p and TP53 mutated. So we have 3 main options in the frontline: chemoimmunotherapy, BTK inhibitor, and BCL2 inhibitor. And the first question I'll try to address is what's the optimal frontline treatment for the 17p and TP53 mutated CLL. So let's see the outcomes with the chemoimmunotherapy. For a start, CLL8 were randomized to FC versus FCR. You can see the black line indicating the 17p, which is the bottom line. The median PFS is less than 1 year in both FC and FCR. In retrospective analysis of patient treated with FCR, the graph in the middle, the red line is 17p, and you can see the PFS is around 12 months. In the ASCEND, where the control arm was PR or P3 kinase with rituximab, the PFS is also less than 1 year. And finally, in the alliance, where the PR was the control arm, you can see the PFS is also, the median PFS is also less than 1 year. So in general, we can we cannot really expect more than 1 year in a median PFS with chemoimmunotherapy in patients with 17p or TP53 mutated CLL as a frontline treatment. Now, let's jump gears and go to the other option, which is the venetoclax or obinutuzumab. And here you can see the CLL14, where the treatment was limited to 1 year with Venobina. And the median progression-free survival you get is around 4 years. So you can see the dotted line that takes place, and that's representing the median PFS for this patient population. So much greater than chemoimmunotherapy. However, we need to see what else is there, because we know relapse 17p TP53 seems to be a less responsive disease. And once you get relapse, you really want to avoid the relapse. That's what I'm trying to say in this disease population. So the next or the final option that we have as a frontline is the BTK inhibitor. Now, RESONATE-2 did exclude 17p deletion, but did not exclude patients with a TP53 mutation. So on the right, actually we'll start on the right, you'll see a pooled analysis from 4 trials in the CLL, with a TP53 with 17p deletion, including the RESONATE-2. And we can see, although they are not the same population of CLL14, they are still comparable in terms of biology, being a 17p and TP53 frontline. And you can see the progression-free survival is longer in patients treated with BTK. I brought in this slide, and we'll talk about ACALA in a minute. On the right is the NIH investigator-initiated phase 2 trial in which 34 patients who had a CLL with a TP53 alteration were treated with ibrutinib as a first-line therapy. We can see at 4 years the progression-free survival was 80%. This is on comparison to the median progression-free survival in the CLL14 of 4 years. Same thing with the ibrutinib. This is the ELEVATE-TN trial where acalabrutinib was evaluated, and we can see that it seems to have a bit of PFS, although this is not the same population, although they are biologically similar with acalabrutinib or acalabina in 17p or TP53. And you can see that at 4 years, you have a 75 progression-free survival. So, to summarize, in this high-risk cohort, community is not a good treatment option. Then Obina, I think we need more data about retreatment in this patient population before we can make a final judgment. But so far, for the time being, with the data available, my preference will be BTK inhibitor with ibrutinib or acalabrutinib as a first choice in the 17p TP53 mutated patient population. Now I'll go to the second question, which is what's the optimal frontline treatment for the immunoglobulin unmutated? And again, we have the same 3 groups or 3 management outlines or algorithms, chemoimmunotherapy, venetoclax, obinutuzumab, or BTK inhibitor. So let's start with the chemoimmunotherapy as we did with the 17p and TP53. So in the shaded red, you can see this is an MD Anderson data, and you can see they have a very long follow-up on that data. And we can see that unmutated, which is the bottom curve, at the bottom curve, the progression-free survival with FCR is around 4 years. So this is in contrast to what you see in purple, which I shaded in purple, which is a flattening of the curve in mutated CLL. So FCR might be a good option for mutated CLL. However, in the unmutated, you have a median progression-free survival of 4 years. Now, let's see other trials. So in the North American intergroup study on the right, we see the FCR gave less than 4 years actually of median PFS in the unmutated cohort. The same noted also in the CLL8, where PFS in the FCR is in the FCR arm is less than 4 years. Let's switch gear to the new novel agent, the venetoclax-obinutuzumab combination. In the CLL14, the unmutated IGVH continue to be prognostic. So there is a separation of the curves between mutated and unmutated, and had an inferior progression-free survival compared to the mutated disease. In the last EHA update, actually, you can see the median progression-free survival for the mutated was just a little short of 5 years at 57 months. So keep that in mind before we move to BTK inhibitors. And we'll be talking about the 2 BTK inhibitors that we have at front line, the Cala and Abratinib. So for the Abratinib, we have the 7 years update with the RESONATE-2. And we can see the median PFS is not being reached until now in the unmutated arm. And actually, you cannot tell which arm. I mean, this is the orange and the purple. Can't really sure which arm is actually mutated and unmutated. It seems that ibrutinib or BTK in general, we'll talk about Acala in a minute, negate this negative prognostic factor of unmutated IGVH. So IGVH mutation status no longer matter in the prognostication of those patients. As I said, you can see the curves literally overlapping to the extent you are not sure which one is mutated versus unmutated. And here at the 7 years of data, this is a 6.5 follow-up is 72% progression-free. So let's go to the ELEVATE-TN, which is the other agent we have is the acalabrutinib. In the 4 years update that was done last year, it shows a similar story to the ibrutinib, where 86 and 89% the combination, 77 and 81 as a single agent in mutated and unmutated respectively. So you actually again, it will be really hard to tell which is mutated or unmutated between those 2 figures, except for the chlorambucil arm, which will tell us that the top figure is actually the unmutated and the bottom is the mutated. So again, it seems that PTK inhibitor negate the negative prognostic factor that IGVH status, mutational status had in chemoimmunotherapy era and subsequently with BCL2 obinutuzumab combination. Just of note, since we are on this slide, which I think will be an area of active discussion and awaiting the trial results, maybe not. There is this now discussion that maybe not all CD20 created equal. There is around now, if you can check between the combination of Acala with obinutuzumab and obinutuzumab single agent, Acala single agent, there's around 9% better PFS with the addition of obina here. This was not noted in the rituximab and ibrutinib in the alliance, so we are not sure what exactly that means. But I think we have much more. We have a lot of study actually comparing 3 or 4 arms, comparing a combination with obina, and to see if there is a role of obina in the future. So to summarize, in the immunoglobulin unmutated, I think chemoimmunotherapy should not be used at this stage. Then obina, I'm not really sure. It gives you 4 years. However, you could retreat, and with the additional of retreatment, if you get a good response and you have another 3 or 4 years, then this is another talk. So we really don't have much data on the retreatment in this unmutated cohort, unlike the 17P where we have some idea. So then the argument can be made to treat with obina. However, so far the best data in the IGVH unmutated disease has been with a BTK inhibitor. So in this slide, I summarize some of what I talked about. So this is what I can extrapolate from the data. So what you start by asking first if the patient or the disease is deletion 17p or TP53 mutated. If yes, then I think the most solid data is with BTK inhibitor. If the answer is no for the 17p and the TP53 mutation, then the next question would be, what is the mutation status? If they are mutated, then the next step is, what is their fitness? If they are old and unfit, I can go with Vin or Bina. Or if you are, if they are young and fit, I think FCR is an option. And the other option will be also to do a Vin or Bina. Now, we don't really know exactly how this would compare. But the MRD rate with Vin Opina in the mutated, in the IGVH mutated CLL is similar to that of the FCR. So I'm not sure. I mean, you really don't have the long follow-up. But if I would guess, I think Vin Opina will soon replace the FCR and this is the only cohort where I can say FCR has a role. Now, this is still in early, as I said, but this is extrapolation from the MRD data with Vinobina. Now, if there is no 17p or TP53 mutation and the IGVH status is unmutated, then the options are limited to novel agents. BTK inhibitor so far has a superiority, but longer follow-up with retreatment on Vin Opina is needed to make a conclusive statement. I tend to place older patient on BTK inhibitor and younger patient on Vin Opina, just taking into consideration the limited data to make a statement and the difficulty for younger patient to actually receive the continuous treatment. And that's why in the figure you'll see them switched, which one is first. So now I will touch a little bit on the side effects, and I will focus on the BTK inhibitor, as they are the continuous treatment and likely to be a problematic more than the time-limited treatment. And I will be in particular focusing on the AFib and hypertension, which I think need more attention. So we have the result of the ELEVATE-RR, which compared the ibrutinib to Acala, and I highlighted in red, in the red columns that you see the hypertension and the AFib. So we do see those two side effects with BTK inhibitor and seem to be less with Acala. So for the hypertension, we have the 22% compared to the 8.6%, and the AFib, the 9% compared to 15.6%. So around 6% difference and 11% difference between them for hypertension and AFib, respectively. However, as I said, this is, you have to think about it in terms of difference-wise, not to over-magnify it. Really, the Acala study, you still have AFib and you still have hypertension, worsening hypertension incidence. Now, we'll touch on this a little more in a minute, but just to highlight this, those two side effects which I highlight in the green, what I want to show in this slide, and you can see the solid red line is a mark of 12 months, and then the second solid red line is a mark of 4 years. And you can see in comparison to the other to the other side effects, where you actually get plateaued after the first year, those side effects, those two side effects, particularly hypertension, is actually increasing in incidence, and then you have to watch for it and treat it aggressively, because this is really what will the discontinuation is more of intolerance or side effect than actually disease progression. So you really have to be on top of this and treat it aggressively. I think this is what I want to show on this slide, and I want to show that there is almost doubling after the first year in the next 3 years. So don't ignore those two side effects after the first year. So we have more data with ibrutinib when it comes to AFib and come to hypertension, just because of earlier use and a longer follow-up. So there is a meta-analysis of 4 RCT. The risk, relative risk was 3.5. And in this report, it was reported cumulative incidence of around 7%. In single center, there was a 16. In the elevate RR, it was 15.6, with a grade 4 of 3.4. Multi-centers, French, Belgium with MD Anderson, and Australian showing around 8.7%. I think if I would guess, and now the variation is largely, it could be a population difference in terms particularly of age as a risk factor, but I think capturing, because in the early studies, the AFib is not, it wasn't very well recognized as it is now and appropriately captured. In the Mayo Clinic, in a Mayo Clinic study of more than 2,000 with ibrutinib, there is an increase at 2-time prevalence compared to the general population, with around 1% incidence per year. So this is for the risk factor for the AFib when you start a BTK inhibitor, and this was done or stratified based on the ibrutinib treatment. As I said, there is more data with ibrutinib than with acala. So it seems that older age, so more than 75, you get a 3.7 hazard ratio of increasing the incidence of AFib. Valvular heart disease comes next, and then hypertension. Now, jumping to the second point, or the second side effect I want to highlight, the hypertension. Unclear mechanism, but it's actually very high. In the elevator RR, it's reported less. It's reported at 22 and 6 for ibrutinib and acala, but I think it's much higher than that from what I see in the practice and from what I see with the prior reports on ibrutinib. It could be reaching up to the 70, and with a 20% to 30% can be grade 3 or more. And this is a problematic because you need to control it, because then you will get into the other cardiovascular side effects. You will increase your AFib risk and will increase the hemorrhagic stroke risk. So this is again to highlight the first point I made about the incidence over time. And you can see this is the Resonate 7 years update. And you can see that like each line, so the gray, the green shaded area is the hypertension, which I want you to look at. And then you can see each year from top to bottom, and you can see actually there is increased incidence, or it doesn't matter, the same incidence, like there is still an incidence of hypertension as you go on the treatment. So this is one of the side effects that you actually need to watch for. It is hypertension and AFib once you get a patient on a BTK inhibitor, and doesn't matter if it is ibrutinib and acala. Both agents, although acala is lower, both agents will have a risk for AFib and hypertension. So. General principles, look and treat reversible causes. Some toxicity like arthralgia, headaches is improve over time. So you can consider, brief interruption, dose reduction, treatment, symptomatic treatment. The hypertension should be treated aggressively and managed aggressively. The thromboembolism prophylaxis is a challenge because the antiplatelet activity and maybe increasing the risk of a bleeding. The other thing they want to say that the general AFib guidelines were made in a different scenario. This is not like a drug-induced AFib. So we are not really sure if the AFib guidelines really apply in terms of intervention and treatment. We'll avoid the strong CYP inhibitors or inducer, and if you have a persistent or recurrent toxicity that cannot be controlled, then you might switch to alternative BTK inhibitor between the two agent or venetoclax according to the clinical scenario. Now, I just want to finally touch on this because most of all the patients are actually taking PPI. Ibrutinib and zanubrutinib, both are pH, well, they have a pH dependency, but it's not affecting that much of pharmacodynamics. So I would, in kinetics, although the kinetics is just the absorption time. So, but for Acala, you really cannot do a PPI or gastric lowering, pH lowering agent with Acala, as it reduced the absorption and reduced the efficacy. So for patient with PPR, H2 blockers, or venetoclax, probably is a better option than Acala, and zanubrutinib once that approved, and we have it in the market. So what is and this is the final slide I have, which is in the future. I think MRD guided treatment is probably going to be the next step in treatment of CLL. We have data from the FCR. We know that when you get an MRD negative to the power of 6, and that retrospective analysis of the FCR data, then you actually has a very lower likelihood of relapsing. So I think the MRD status will be something to look for in CLL treatment, and I think the Captivate trial is set well to answer this question. But however, the Captivate is not this the 4 versus 6 is actually 4, but it will give an answer on the MRD guided approach. Mutations, persistent mutation, BTK inhibitor, BTK itself, or PCL2 itself, other antibiotics, increase in MCL1 in the venetoclax treated, other acquiring a new mutation like a TB53, other mutation that coexist in the CLL clone like Notch1 or S3B1. So the whole prognostic field of CLL will likely to be different in few years than it is now. We know now that 11q does not mean much with the novel agents. We know the IGBH mutation status no longer carry that negative prognostic with the PTK inhibitor. So the prognostic value of set parameters that was done in the chemoimmunotherapy era might not be as useful in this new era of novel agents. And finally, I think the combination BTK inhibitor, PCL2 inhibitor plus or minus CD20 antibodies are probably going to be very active and going to be a main stem in treatment of CLL in the future, and maybe achieving a level of a cure, which is something new or a new world in the CLL world. And the reason, because of BTK inhibitor, there is a PCL2 inhibitor, there is a synergy in the preclinical studies. the mechanism of action is different between the two. The toxicity may be overlapping for diarrhea and neutropenia maybe with zilovertinib and as a BTK inhibitor. And they work on a different cellular compartment, so one on the lymph node and one on the bone marrow. And with that, we'll conclude and thank you. I hope you guys enjoyed this presentation and I hope it was somewhat informative, and thank you very much. I'll be happy to take your questions.
Okay, excellent. Thank you, Dr. Mansour. Very informative and very comprehensive and very balanced talk addressing all the main important topics in a CLL. So we'll leave the questions on this interesting talk with Dr. Salim's also presentation. So we'll proceed with Dr. Salim Al-Dahdah, as introduced before, consultant hematologist and stem cell transplant and Princess Noor Oncology Center. So update from ASCO and EHA on a CLL. Dr. Salim.
Thank you, Mr. Chairman. I would like to thank the Saudi Society of Blood Disorders and Dr. Amal, Dr. Firas for inviting me to speak to you today. So in the next 20 minutes, I'm going to discuss some of the recent CLL update from the last ASCO and EHA. I'm going to discuss 5 different clinical trials, 3 trials in the upfront therapy, which are the blue trial, Elevate-TN trial, 4 years follow-up, the Captivate trial, the fixed duration cohort follow-up, and in the relapse refractory CLL setting, I'm going to present 2 recent presentations, the Albine trial and the Elevate-RR trial. So the first trial I'm going to present today is the blue study, which is a comparison of fixed duration of iprotinib and venetoclax I plus V versus chlorambucil plus obinutuzumab CLB plus O for the first-line therapy of CLL, which was presented by Dr. Keter in the last EHA. So this trial was an international open-label randomized phase 3 clinical trial in patients with previously untreated CLL aged more than 65 or less than 65 with multiple comorbidities. They were randomized to receive a lead in iprotinib for 3 cycles, 420 milligram per day, followed by 12 cycles of iprotinib plus venetoclax. The control arm was the chlorambucil obinutuzumab in the typical dosing of chlorambucil 0.5 milligram per kg, day 1 and 15 for 6 cycles, and obinutuzumab 1 gram per day, day 1, 3 doses in the first cycle, and 1 dose in the subsequent cycles for a total of 6 cycles. The primary endpoint of the trial was progression-free survival. So this is I'm showing you here the baseline characteristic. Elderly people, the median age was 71 in both arms. Multiple comorbidities, the median CIRS score was 9 and 8 respectively. Unmutated IGHV was present in 51% in each arm. They did not allow 17B minus to be included in the trial, a 17B minus patient, but TP53 mutation was present in 6.6% in the I plus V and 1.9% in the control arm. So if you look at the progression-free survival, the clear separation of the curve with a median progression-free survival not reached versus 21 months in the chlorambucil obinutuzumab arm, the control arm, hazard ratio of 0.21 with a significant p-value. The progression-free survival benefit was clear across all pre-specified subgroups. And if you look at the CR/CRi rate, the overall response rate was similar, but there were higher CR/CRi in patients receiving the iprotinib venetoclax, 38% versus 11% in the control arm. The undetectable MRD levels were higher in the iprotinib venetoclax, 51% in the bone marrow versus 17% in the control arm, and 54% in the peripheral blood versus 39% in the control arm. This 3 months after the end of therapy and by NGS. With regard to this MRD, if you look at the sustainability of this MRD in patients who received I plus V peripheral blood undetectable MRD was 55% at 3 months and 49% at 12 months. So maintained, only the difference here is 6%. But in patients receiving chlorambucil obinutuzumab, the undetectable MRD in the peripheral blood was 39% at 3 months and then dropped to 12% only at 12 months. Significant drop. With regard to safety profile, so the grade 3 or more adverse event occurred in 75% in the ibrutinib venetoclax versus 69% in the control arm, with neutropenia, infection, hypertension were more common, 7.5% versus 1.9%. This is grade 3 hypertension. Atrial fibrillation, 6.6% versus 0%. The overall survival was similar between both arms. Hazard ratio was 1, with 11 deaths in the I plus V versus 12 deaths in the control arm. So in conclusion, the all-oral once daily fixed duration I plus V demonstrated superior BFS as compared to chlorambucil obinutuzumab as the first-line treatment of CLL, independent of the CIRS score and other covariates. Undetectable MRD was maintained at 1 year. The safety profile was consistent with the treatment in the elderly comorbid population. And this is these first randomized data demonstrate the positive clinical profile of fixed duration of I plus V in older patients. The second trial in the upfront therapy was touched by Dr. Mansour in his talk, is the study of the Elevate-TN trial, the 4 years follow-up, in which acalabrutinib was used with obinutuzumab and as monotherapy versus the control arm obinutuzumab chlorambucil in treatment-naive CLL patients. So this was a phase 3 randomized clinical trial. They included 535 patients. 17B deleted patients were included in the trial. The primary endpoint was progression-free survival by IRC assessed, mainly for acalabrutinib plus obinutuzumab versus the control arm. So for the baseline characteristic, you look, the median age was 70, 71. Cytogenetic group, they included patients 17B and TP53, 14% in the acalabrutinib obinutuzumab, 12.8% in the acalabrutinib monotherapy, and 14% in the obinutuzumab chlorambucil. Patients with unmutated IGHV were 57%, 66%, and 65% respectively. This Kaplan-Meier curve, you have seen it in Dr. Mansour's presentation. So superiority of both acalabrutinib arms, acalabrutinib monotherapy and acalabrutinib plus obinutuzumab, 87%, 78%, and 25% for the control arm. The addition of obinutuzumab seems to have a benefit in the acalabrutinib arm, although the study is not powered to demonstrate the difference. So there was a 9% difference, and it was statistically significant with a hazard ratio of 0.56, favoring addition of obinutuzumab to acalabrutinib. So in patients with 17B deletion TP53, the median progression-free survival was not reached, 76, 75% in both acala arms versus 18% in patients who received the control arm. With regards to adverse event, the atrial fibrillation of grade 3 or more occurred in less than around 1% in the acala arm, and 3.9% of the atrial fibrillation of any grades. Major bleeding of grade 3 or more occurred in 2.8% in the both acala arms. Hypertension occurred also of grade 3 or more in 3.4%, 2.8% in the both acala arms, and 3.9% even in the obinutuzumab chlorambucil arm, the control arm. Infection were more in the acalabrutinib obinutuzumab, 23% grade 3 or more infection versus 16% in the acala monotherapy versus 8% only in the obinutuzumab chlorambucil arm. So in conclusion, with longer follow-up at 46.9 months, we see that the progression-free survival, the efficacy of both Acala arm was maintained relative to the control arm. And the estimated progression-free survival trended in favor of the combination of the acalabrutinib plus obinutuzumab for 87% versus 78%. So the safety was consistent with the interim finding, with a slightly lower incidence of cardiovascular event. Just note that as I mentioned, the grade 3 infection were more common in the Acala obinutuzumab arm than the Acala monotherapy. The third abstract I'm going to present today in the frontline therapy is the update of the Captivate study, the fixed duration cohort of using obinutuzumab plus venetoclax in CLL patient, presented by Dr. Paulo Ghia in the last ASCO. So the Captivate trial had two actually cohort, the MRD cohort presented before, and the new cohort is the fixed duration cohort. They get 3 cycles of ibrutinib lead-in followed by 12 cycles of ibrutinib plus venetoclax. So they included 159 patients previously untreated CLL. The primary endpoint was CR/CRi rate in patients without 17B deletion. This is the cohort, the disposition of the patient. 159 patients were included. 147 patients completed the 12 cycles of ibrutinib venetoclax. These are the baseline characteristics. Median age was 60. The high-risk features, the unmutated IgG was in 56% of patients. The deletion 17B and TP53 in 17% of patients. So the primary endpoint, as I said, was the CR rate of the fixed duration of therapy, and the CR/CRi rate of the all treated patient was 55%, and patient without 17B was 56%. This compared favorably to the CR rate, for example, to the chemoimmunotherapy FCR in the CLL-10 trial. They had a CR/CRi rate of 40%. It may have a higher CR rate, although the cross-trial comparison is difficult. So the high CR rate was independent of the subgroup, including those with high-risk features. If you look at the undetectable MRD by flow cytometry, it was achieved in a high number of patients, 77% of patients in the peripheral blood and 60% of patients in the bone marrow. The progression-free survival at 2 years was 95% of the whole cohort, and the overall survival was 98%. If you look at the patient, specifically at the patient 17B and TP53 mutation, the CR/CRi rate was high, actually 56%, and even undetectable MRD was high. So if you look at the peripheral blood, undetectable MRD was 81%, and the bone marrow was 41%. The lead-in use of ibrutinib for 3 cycles before starting the combination led to a reduction in the TLS risk. So a patient who had high baseline TLS risk, they went down to medium or low TLS risk with the use of this ibrutinib lead-in. If you look at the most common adverse event of grade 3 or 4 toxicity, neutropenia in 33% of patients, infection in 8% of patients, hypertension 6% of patients. With regard to AFib, 4% of patients, major hemorrhage 2% of patients. But remember, these are young people with a median age of 60 years. Adverse event leading to discontinuation, 5% overall, and adverse event leading to dose reduction, 21% overall. Dr. Paulo Ghia presented that 8 patients progressed after this fixed duration of treatment, and they all were retreated with single-agent ibrutinib. So 6 out of these 8 had responded with PR, with 2 patients pending response evaluation. So in conclusion, the ibrutinib plus venetoclax met the primary endpoint of CR/CRi rate of 56%, with similarly high rate overall in patients with high-risk features. and high rates of undetectable MRD and 2 years progression-free survival and overall survival of over 95%. Favorable safety profile. Result from the fixed duration cohort probably correlates consistent with the MRD cohort. Total 332 patients of the two cohorts were treated in this study. And this support the use of fixed duration of ferrotinib venetoclax as once daily chemo-free therapy-free regimen in patients with upfront therapy of CLL, SLL. So I want to shift gears to the relapsed refractory setting. I have two trials to present. The Albine trial, which was a phase 3 randomized clinical trial comparing zanubrutinib versus ibrutinib, was presented by Dr. Hillman as a late-breaking abstract in the last EHA. So the Albine trial was an international open-label phase 3 clinical trial randomizing patients with relapsed refractory CLL to receive either zanubrutinib at a dose of 160 milligram BO BID versus ibrutinib at the typical dose of 420 milligram BO daily. The primary endpoint was not the progression-free survival. The primary endpoint was non-inferiority and superiority of investigator-assessed overall response rate. And survival was a secondary endpoint. So these are the baseline characteristics. Median age was 67 in both arms. Patient with 17B and 17B deletion, TB53 mutation were 20% in the zanubrutinib arm, 18% in the ibrutinib arm. So the study met its primary endpoint with higher overall response rate with zanubrutinib versus ibrutinib, 78% versus 62%. Mainly the CR rate were low, but mainly because of higher PRs with the zanubrutinib versus ibrutinib. But if you look here at the PR with lymphocytosis, actually numerically was higher in the ibrutinib versus zanubrutinib, 18% versus 10%. Patient 17B deletion, 24%, 24 patient in the zanubrutinib arm, 26 patient in the ibrutinib arm, 17B or TB53 mutation, 83% response rate in the zanubrutinib arm, and 53% in the ibrutinib arm, higher with the zanubrutinib arm. With regards to the 12 months progression-free survival, which was a secondary endpoint, 95% with zanubrutinib versus 84% with ibrutinib with a hazard ratio of 0.4. No difference in the overall survival, did not reach statistical significance. So this is the progression-free survival curve, higher progression-free survival in the zanubrutinib versus ibrutinib, 95 versus 84. If you look at the adverse events here, any grade 3 or more adverse event occurring 55% of patients in the ibrutinib arm versus 51% in the in the zanubrutinib arm, 55% versus 51% in the ibrutinib arm, and fatal adverse event 4% versus 5.8%. Adverse event leading to dose reduction 11% versus 12%. If you look specifically at the cardiac and disorders and atrial fibrillation, so any grade cardiac disorder were higher in ibrutinib versus zanubrutinib, 25% versus 13%. If you look at the atrial fibrillation at any level, any grade, higher also with ibrutinib versus zanubrutinib, 10% versus 2.5%. But again, the discussions come back to the grading. If you go to grade 3 or more, AFib was 1.9% in ibrutinib versus 1% in zanubrutinib. Major hemorrhage of grade 3 or more was similar between both arms, 2.9%, and hypertension of grade 3 or more was similar between two arms, 10%. So in conclusion, the interim analysis of the phase 3 Albine study in patients with relapsed refractory CLL showed that zanubrutinib had a higher superior response rate and improved PFS and a lower rate of atrial fibrillation and flutter of any grade as compared to ibrutinib. And these data may suggest that more selective BTK inhibition with more complete and sustained BTK occupancy may result in improved efficacy and safety outcomes. The last abstract I'm going to present today is the Elevate-RR trial, which is a head-to-head comparison of acalabrutinib, a second-gen BTK inhibitor, versus ibrutinib in previously treated patients with CLL. was presented by Dr. John Baird in the last ASCO. So it was a phase 3 randomized clinical trial. 533 patients were included. They were randomized to receive either acalabrutinib at a dose of 100 milligram BO BID versus ibrutinib at a dose of 420 milligram BO daily. So if you look at the baseline characteristic, median age was 65% in the both arms. They had actually in this trial a very high percentage of patients with high-risk cytogenetics. So if you look at patient 17B deletion, 45% in each arm had 17B deletion. 46 and 47% had complex karyotype, and more than 80% in each arm had unmutated IGHV. And they had a median number of prior therapy was 2 in both arms. So it looks like higher risk population than the Alpine trial population. So if we look at the study met its primary endpoint, and it showed non-inferiority of acalabrutinib when compared to ibrutinib. The progression-free survival was similar with a hazard ratio of 1. So exactly similar progression-free survival in both arms. The progression-free survival was comparable across different subgroups with no difference between both arms. And if you look at the secondary endpoint, which included any grade of atrial fibrillation and flutter, it was actually lower with acalabrutinib than ibrutinib, 9.4% versus 16% in the control arm. An important thing to note here that the onset of AFib actually in acala is later than ibrutinib. So the median time to onset of atrial fibrillation was 28 months in the acala, more than 2 years, versus 16 months in the ibrutinib arm. The overall survival was similar between both arms. Grade 3 infection were all, grade 3 or more infection were also similar, and the incidence of rectal transformation was similar between both arms. With regard to grade safety summary, grade 3 or more adverse events were 68% in the acala and 74% in the ibrutinib arm. This table shows you the common adverse event. The one highlighted in red, in yellow. These are the ones that reach statistical significance. So we have higher grade of the higher incidence of diarrhea in the ibrutinib, higher incidence of headache and cough in the acalabrutinib, higher incidence of arthralgia and hypertension with ibrutinib with any grade. If you look at the atrial fibrillation of any grade was higher with ibrutinib, but for grade 3 or more, atrial fibrillation was not different between both arms. With regard to grade 3 or more infection, exactly similar between both arms, 30% of grade 3 infection in both arms. So this graph, you have seen it in Dr. Mansour's presentation. There is a trend toward a lower incidence of atrial fibrillation and flutter with acalabrutinib, and higher with ibrutinib and higher hypertension. So in conclusion, the acalabrutinib showed non-inferiority to ibrutinib in the primary endpoint of progression-free survival. It had demonstrated lower frequency of some of the adverse events. The atrial flutter and fibrillation of any grade was significantly less with acalabrutinib versus ibrutinib. Hypertension was also less. These results demonstrate that acalabrutinib could be better tolerated and had similar efficacy in patients with previously treated CLL. I conclude here. Thank you all for listening.
Okay, thank you, Dr. Salim, and thank you, Dr. Mansour. We are at 10 o'clock now. By this time, we should have been also finishing the event, but because of the great 2 presentation, I think we'll have 10 minutes to maybe ask a few questions, and I will open it also for the other speakers with us, Dr. Riad and Dr. Riad Al-Faqih, if they have any questions. But I would like to start with asking Dr. Mansour about the switching between the different BTK inhibitors with the first and the second generation due to toxicity profile. What's your take on this? And give you an example. If we have a patient already developed, let's say, grade 3 atrial fibrillation, still responding to the BTK uncontrolled with the treatment, would you switch to another BTK? Would you go to the BCL2 inhibitor? When you would switch because of the toxicity or because of the disease progression in one BTK and switching to other?
So if so, let's start with the last one because it's probably easier. If you progress to a PTK, you are unlikely to respond with the currently available PTK, which is a calaprotinib. Now there is the compound Aloxo 305 periprotinib. It has a name now, and this is going into phase 3 now. And this is actually a very promising in that those with a PTK resistant actually and those who are progressed to PTK will more likely to get response with this agent. So, but that's an unconvalent binding agents that a different spectrum than what we actually have now. So progression, switching to a different PTK is probably not going to work. I think you probably need to switch to alternative class, which is BCL2 inhibitor. Some will do the combination of BCL2 inhibitor with PI3 kinase. Some can do the PI3 kinase with CD20. So anyway, you have options, but I think switching to the alternative BTK inhibitor at this stage with Cala as the other option or ibrutinib is the other option is not likely to go into work. Now, as for the intolerance, most actually the side effects they do not occur. If I can share a screen here, and that will be. So this is with zanaprotinib and abratinib. So comparing abratinib and Acala to zanaprotinib. So a lot of the side effects actually do not cross-react between the two. However, the AFib and however, to be more careful with the wording. If you have a grade 3 or 4 of a side effect that can be fatal, like you get a stroke or you get an AFib that is grade 3 or 4 that you need a pacemaker or cardioversion, then I would be very cautious switching to the other BTK inhibitor. Now, we are talking about, like, if you say like a 15% incidence with a ibrutinib in AFib, as an AFib, a flutter, you're talking still about 9% with a calaprotinib. So this is not like the other drug does not have that overlapping toxicity. It actually does. So I would be careful with serious side effects. But the more annoying chronic side effects, like a rash, dry skins, diarrhea, can be, I think you can do it. And I think you probably will have more likely to have good response with no cross tolerance or cross side effect between the two agents. I hope that answers the question.
Thank you. Dr. Salim, two excellent presentations into the fixed duration with the glue and also the second arm from the capitative study. So where would you put that into the algorithm, either for the elderly patient or for the young patient as a front line therapy? We've seen the algorithm presented by Dr. Mansour was not taking into consideration the fixed duration as a front line therapy. Ibrutinib, venetoclax, is the evidence enough? Would you wait for more data on that aspect?
Thank you very much for the question, Dr. Umbarak. Actually, it's an ongoing debate when to consider this as a frontline therapy. So the frontline therapy have been changed dramatically in the last decade. We know 10 years ago, we didn't have any of these agents. We were using just chemotherapy. chemoimmunotherapy, and now we have these all novel agents. I think the synergistic action of BTK inhibitor with BCL2 inhibitors that was touched on by Dr. Mansour will have a great impact probably on the response as we have seen in these two trials, higher CR rates, higher MRD negativity. And probably this would translate into a longer progression-free survival. The problem that the follow-up of those trials is short. The follow-up did not exceed 2 years. Probably we need longer follow-up to see whether this effect is sustained. I wouldn't switch practice based on the data we have now. Probably we need longer follow-up to consolidate our knowledge. And there is a lot of ongoing trial we'll see in the upcoming 1 or 2 years comparing these agents, like one trial comparing ibrutinib venetoclax versus venetoclax obinutuzumab versus ibrutinib monotherapy in the upfront therapy. So this is one of the trials that would answer the question.
Good. I think we'll have maybe the final question. I have this question from Dr. Majid Al-Ahmadi on the same direction about the fixed duration combination of ibrutinib, venetoclax, but this trial did not include the 17p deletion patients. So would you consider the same strategy for those patients? If you will consider a fixed duration of ibrutinib, venetoclax, the question for both of you, Dr. Salim and Dr. Mansour.
So if I might just add a complaint and probably answer this question too, is the fixed duration, the combination fixed duration is probably going to be the future. The harder question is for how long and when do you actually stop? And so I would simplify the questions is, would combinations better than sequential? I think the combination will be better if you do it. Now, the second question, if the combination would going to be better, is there a specific patient population? And I think the high risk. So if we see I think the longest one that is currently available is Nitin Jain paper, which was initially published in New England. Then he updated it a few months ago in the JAMA Oncology, which is the combination ibrutinib and venetoclax. So in this patient population, actually, you have the 17p and you have the TP53, and actually in those patients with a 17p and TP53, it seems that the negative prognostic factor, at least at the 3 years follow-up, is not there. So really, we don't know. But I guess based on this early data, this is probably the, I mean, this is not approved. So you probably don't want to do it outside of clinical trials. But this is, I think, the patient population that you probably will get the most benefit from is the high risk, the TP53, 17p, who get, and now one difference with Nitin Jain, and actually I want to comment on the law because he had actually a higher MRD rate, MRD negativity, and the MRD negativity at 1 year, it was close to that of the current 12 months combination. But because the study actually he had it for 24 months, so 2 years combination. At the 24 months, he actually had around 15 or 16 percentage increase. It's around 66% MRD negative. So again, the duration, it's going to be a lot of what determined, and maybe the MRD, he did not incorporate the MRD, but maybe in the MRD will have a say in that. And yeah, I think in his last report, the 3 years progression-free survival is 93%. So this is not something we have heard about in CLL.
Just one small comment regarding the question. So we had the 2 trials I presented, the GLUE trial, which is including elderly people and people with comorbidities. They excluded patients 17b deletion. But on the other hand, the Captivate trial, which was a study for a younger population, median age was 60, they actually included patients with 17B and TB53, and there were higher MRD negativity. We had short follow-up of those patients for 2 years only. So probably a longer follow-up is needed to see whether the curve dropped down like what we have seen in the CLL14 and 17B deleted patients.
Excellent. So with that,
I think the glow here, I think whoever asked the question, the glow, because the randomization was to chlorambucil, so they actually did exclude 17B, TB53, because otherwise it's really unethical to randomize.
Yes.
so with that comment, I would like to thank our speakers tonight, Riad al-Faqih, Dr. Riad Dada, and Dr. Mus'ab Damlaj, who moderated the first session, Dr. Mansour Al-Faiz, and Dr. Karim Al-Dahdah for the CLL. I would like to thank the SSPD for organizing those events. And next week, we'll have the third also series about the leukemias and MDS with the same very strong program. So I would like to invite you all to that on the same time, same day next week. With this, I would like also to thank the President, Dr. Furan Salfayah, and the Vice President, Dr. Amal Behani, for taking the lead of this continuous education, and for all the participants who reached up to 1,000 tonight, which means the interest and the motivation to attend such educational sessions. I wish you all a good night and thank you, and have fun. Enjoyable weekend.
Thank you very much. مع السلامة.
Assalamu alaikum.